Welcome to our webinar today. We are going to talk today about how to use market-specific data to make your organization successful in value-based healthcare. This topic is incredibly relevant in the healthcare space today, and it's going to continue to get more relevant as time goes on. And our speakers in a few minutes will tell you exactly why that is. My name is Dave Bailey. I'm the head of marketing for Stratazan. We are a healthcare data analytics company in Nashville, Tennessee. We were recently acquired by a company called Syntellis Performance Solutions. They are a leading provider of enterprise performance management software, data, and intelligence solutions for healthcare organizations. So we, as our two companies, we are really excited. We think we're going to be able to bring to market a really broad range of data-focused solutions to help financial, strategic, and clinical planning. So I'm going to go ahead and introduce our speakers now. We have two great speakers today. Our first one is Michael Falkenberry. He is our VP of Strategic Advisory Services here at Stratazan. Honestly, Michael is one of the most knowledgeable persons I have met in healthcare. So has a really good background in healthcare, has worked at QHR, Accent Care, and Methodist Health System in Dallas. So again, really, really knowledgeable person in the healthcare space. And then similar, we have Charles Glover, who is Stratazan's Director of Strategic Solutions. He has a really strong specialization in payer relations and managed care. So really two good speakers today who are really going to be able to give you the background, the current goings on and the future of value-based care. Before we get started, I just want to remind people that the way this will work, we have a questions box that's in the panel on the right-hand side of your screen. So if you have a question, just put it in there. At the end of the session, we'll have a Q&A and answer all your questions. So now I'm going to turn it over to Michael and Charles.
Awesome. Thanks, Dave. Confirming you can hear me, and I'm going to go ahead and jump in and cover what we're going to talk about today. So like Dave said, value-based care is a really big topic in healthcare, and it has been for the last decade or so. Our goal today is not to talk through every component of what it means and every component of how to be successful, but more specifically, how can data, how can market understanding, how can market data help organizations like yours be successful in value-based care? What are the things we are looking for when we're looking at a market, and how are customers of our own platform using it to assess value-based care? So the two objectives we're going to cover today: one, understand how these models have evolved over the nearly 5 decades, and really more specifically in the last 5 to 10 years, where things currently stand and where might things go next. And then we're going to look more specifically at how market-specific data and insights can inform physician relationships, payer negotiation, marketing strategies, and really give you a good understanding to help offset the investment or loss and the risk potential associated with value-based care. So really two finite objectives. We're going to talk some more qualitative historical context, and then we're going to jump into some data that we've pulled straight from our platform. So like Dave said, please put questions in as you go, and we'll have some time at the end to talk through those. So our agenda today: a brief history of value-based care. Where is the market today and where might it be going? We're going to talk data analysis, use a specific market example. What are some things that we're looking for? What are some things we're seeing from our customers that drive value-based care decision making? And then leave you all with a few key takeaways before Q&A. So with that, I'm going to jump right in to a brief history of value-based care. The term value-based care has really come into existence in the last decade or so, but the whole idea of value-based care really spans back to the 1970s and maybe even before. In the 70s, the first HMOs were created as an alternative to our existing fee-for-service model, right, which is a value-based model. You do 10 procedures, you get paid for 10 procedures, right? That has been the bedrock of the healthcare payment system since it evolved to what it is today. But HMOs really came around in the 70s, and from the 70s and even into the 90s, you saw a significant shift in the way that payer networks began to develop, the way that employer-sponsored healthcare, the way that really healthcare was managed from a payment perspective. It really created a seismic shift in networking, contracting, and the way that organizations contract with payers. And so from the 70s all the way into the 90s and 2000s, that was really where a lot of the focus started. The term value-based care moving into the 2000s really started to take this very simple formula of value equals improving quality, reducing cost. In the first attempts of the Affordable Care Act, it was announced as part of the triple aim. And really, you see that even prior to the Affordable Care Act, even into 2005, CMS, the Centers for Medicare and Medicaid Services, were really taking a stab at risk sharing. This was in a physician group payment model in 2005. You all will see a trend if you've not seen it play out in the market, that Centers for Medicare and Medicaid Services like to push the envelope with regard to value-based care through demonstrations projects. Things like the Affordable Care Act certainly put a lot of emphasis on this, but ACOs, bundle payments, patient-centered medical homes, all demonstration projects that CMS has piloted with certain organizations to understand, gain proficiency, kind of get a proof of concept, a true product testing model before it rolls out wider. And we typically see that demonstration projects under CMS, if they're successful, if they are starting to take flight, become part of other payer contracts, that payers really take notice from what CMS is doing and adopt that into some of their own contract. So 2005, we really see Medicare getting into the risk sharing game. 2008 to 2011 is where we see the first mention of accountable care organizations, or ACOs. It was first termed in 2008, and then it was actually written into the language of the Affordable Care Act. Moving into 2012 to 2018, ACO programs really took off running. We're seeing private payers and Medicare, even some managed Medicaid organizations across the country rolling out ACOs. Medicare ACOs covered in a Medicare shared savings program covered 33 million lives by 2018. So going from zero or relatively low amount to 33 million over the course of 5 to 6 years. In 2015, Health and Human Services, which CMS falls under, set a goal to have 85% of Medicare fee-for-service payments tied to quality initiatives and incentives by 2016. In 2015 to 2018, a slew of new value-based programs were also introduced, including bundled payments, BPCI being a big one of those that hit a bunch of inpatient facilities, direct contracting models, patient-centered medical homes, as well as some newer iterations of the ACO model. And from 2015 to 2018, you're really seeing a lot of demonstration projects taking off on the Medicare front, but also private payers, commercial payers, and Medicaid getting into quality-based incentives, value-based programs, and a lot of pilot programs. I was working in home health in 2015, and we were talking with payers about capitated payments. We were talking about value-based payments to tackle social determinants of health within home health as early as 2015, as payers were coming to the table seeing value and reducing variations in spend, improving quality outcomes, which ultimately help insurance companies manage populations better, manage risk better, and have more predictable earnings as well. In 2020, we saw a lot of the CMS programs put on delay, a lot of demonstrations kind of put on halt. And so all the goals of having coverage, fee-for-service payments moving into a value-based world took a back seat to everything our healthcare industry was facing in 2020, 2021, and we're just now seeing that start to pick back up. So a lot of change, a lot of process, but what you're seeing is a lot of trend in that Medicare driving a lot of the change, putting a lot of the impetus on providers to come to the table to share risk, to help them understand where might this go, and put a lot of the care in the provider's hands from a reimbursement standpoint. I mentioned the growth in ACO contracts and membership coverage. You're looking here as a trended graph from 2010 through early 2021. The blue bar is the total amount of ACO contracts around the country. The orange bar is Medicare, and the yellow bar is commercial. So you see there, all of them gaining speed up until 2017, 2018. and then sort of plateauing off in 2018 onward into 2021. But commercial contracts actually having quite a few more contracts out there than Medicare, and you even see some slow, steady growth from Medicaid programs, which vary state by state. But all in all, a lot of growth happening in ACO coverage over the course of the last decade. In terms of covered lives, similar story from 2010 to 2021. You see that growth and then plateau in terms of the number of covered lives. Blue bars here are covered lives. Orange is the total number of ACOs. So you see they're very much in line. And what this tells us, right, is that there are over 30 million individuals, beneficiaries who are tied to an accountable care organization where there are incentives for value. But what this also tells us is there are a lot of contracts out there from an administrative standpoint, from a shared risk, from an outcomes tracking and measurement standpoint. There are a lot of different ways that healthcare organizations are being asked to track, to understand, to manage these things from a contracting standpoint, from a patient population standpoint, from a provider alignment standpoint. And so this is actually one of the underpinning issues we're seeing is that it's driving a lot of complexity in our healthcare system, and we're even seeing organizations like CMS and other payers taking aim and understanding that as well. So with all that, I want to talk a little bit about where we are today and where might it be going. Today, about 60% of Medicare payments are still tied to fee-for-service. 41% of payments stem from value-based care reimbursement models. 20% of those are fee-for-service with value and quality incentives baked in, and 39% are still strictly fee-for-service. So we still are a long way to go of that 85% goal set for 2016, but we are seeing some traction. But again, 4 out of 10 still tied to fee-for-service. Medicare Shared Savings ACOs generated about $1.7 billion in savings across 11 million beneficiaries in 2021. CMS is tweaking programs with a new focus on health equity. We are seeing that play out in several different states. There are grants, there are certain projects out there where health equity is now being a big part of how organizations are reimbursed. And it's becoming a large part of the vocabulary within data collection, patient records, and understanding patient populations and tracking outcomes tied to race, ethnicity, sexual orientation, language. The health equity component is a really interesting one because payers are starting to address this in a meaningful way. We're seeing a lot more collaboration between payers and providers, a lot of unique contracts out there. And we're also seeing more providers say they'll take on more downside risk this year. A lot of providers have been able to take upside risk and minimize the downside risk, and a lot of payers, as of late, are pushing providers to take on more downside risk. And as more and more organizations are getting more comfortable with value-based contracts, again, 6 out of 10 probably have some kind of a contract in place, you're seeing more comfort taking on downside risk. Charles, you work quite a bit with our clients and our customers. I'm curious, what have you been hearing on this front in terms of how are organizations focusing on value-based care, and what sorts of questions are they asking as they are looking at data?
Yeah, thanks, Michael. Well, you know, if we're talking about volume, you know, it's still for providers still very much top of mind. The way that our clients are thinking about their markets and you know, volume in particular, it's changing, right? So historically, as our own Tony Camerata would say, you know, in healthcare as a provider, you can increase your bottom line in 2 ways. You know, you can treat more patients, or you can make more on those that you treat. That's still true today, but it is, again, it's shifting, it's becoming more nuanced, right? So we're moving from a world of just treat more to treat the right kind of more, right? And that's what we're seeing with our clients. So those strategy and biz dev teams that we work with, they're shifting from and again, moving towards a value-based care world, they're shifting from who is walking through my door and how do we make them healthy, kind of a pure volume play, to why are they walking in my door and how do we keep them healthy, right? So with that, they're looking at more effective and lower cost care paths.
Great. And I really like we mentioned there on the volume part that the focus being really moving from just looking purely at volume and thinking about volume and then some. I think it's a really important distinction there. Thank you. So I want to just level set very quickly before we jump into where we are today and where we're heading to talk about what are we seeing out there in terms of payment models. So the traditional look, right, fee for service is volume driven payment. You are incentivized based on the volume, the number of heads that walk in your doors and what you get paid for. There are no links to quality historically, or there are very few. In fact, many organizations that I've worked with are not actually aware of the quality incentives that might exist within their contracts, right? Because they're minimal, they're small, or they're hard to track. So for an organization, the fee for service model offers relatively low financial risk. Now, we did see in COVID-19 pandemic in 2020, 2021, right? When volume takes a hit, when fewer patients are walking in the door, well, there is financial risk where you are getting fewer people through your doors, you're making less money. And we saw federal government step in to address that as well with support in dollars for that. As you move kind of up the spectrum, you're moving into some linkage to value-based care. So an adjusted fee for service model. You're incentivized for volume, but there might be links to quality. So you will be paid out at your full amount if your readmission rate is within a certain threshold or below a certain number, as a very simple example, where they are starting to incentivize volume or pay you out based on it, but it's still very much based on volume. So there is some risk for organizations, but it's a low amount of risk. As you move up the spectrum a little bit more, you're seeing value-based payments. So this is things like bundled payments where you're getting maybe a set amount based on quality metrics for certain procedures, direct contracting, where there's incentives for quality, and there's some linkage to volume. So the volume matters, but what you're doing on the quality standpoint is how you're sharing savings, how the organization is recognizing benefit. And there's moderate risk involved there, right? The more quality is coming into play, the more it's on the organization to manage those populations better. And then as you kind of move to the other end of the spectrum, you're getting population-based payments, where instead of it being based on individual patients or encounters or discharges, you're getting pure maybe capitation, where you are saying there are 1,000 people in this population, we will pay you $10 per person per month to take care of them however you see fit. So that is for the organization to say, okay, we can deliver, we can put the right resources in place, but it is on us to get them perhaps preventive care, to keep them out of the hospital in a high cost setting where it's appropriate, to reduce readmissions. And every dollar we can generate under that is savings, dollars we can reinvest into that population, and dollars that help the organization. So you're seeing on the far end of the spectrum is population-based payments. And obviously, as you move from left to right on the screen, provider alignment and understanding of your market really become more and more of a factor, right? On the left side, you want to know your market, you want to know your volume, but on the right side, you really need to know your market. You really need to understand those risky populations within the group that you're serving to understand what is our financial risk, what's our quality risk, what's our clinical risk. If we lose a provider in this population, what is that going to do to the way that we're able to treat patients from a continuity standpoint, right? These are all things that play into the conversation as you move from left to right. And so, as you look at this, it's easy to say, this is where we thought we would be. 5-10 years from now, organizations were being talked to about value-based care and the goal of 85% tied away from fee-for-service by 2016. There is this feeling out in the healthcare world that we would be here by now, when in reality, we're still seeing 40% tied to fee-for-service. I would argue that we are much closer towards the left than we are the right. In the conversations that I've had with healthcare organizations, I think they feel that as well, that we're still very much being asked to balance prioritizing value, but prioritizing volume. And we have a lot of systems in place that really don't allow us to do one or the other effectively. And we're really kind of bridging the gap there. So we're still not where we thought we'd be, and that's presenting its own challenges. The movement to value-based care is continuing to evolve with lots of twists and turns. I don't proclaim to understand everything about where it's going, but I do know a few things about where CMS has said they're going. CMS has stated that they want to have 100% of traditional Medicare beneficiaries be part of an ACO by 2030. They're seeing a lot of benefit happening in the ACO space with regard to savings, organizations, understanding, taking a play in risk management, better data, better outcomes reporting. And they're seeing a lot more private industry getting involved to support that as well. They say that they plan to get there by having fewer competing payment models, so reducing that administrative burden, incorporating health equity as part of every model or program by 2030, focusing on provider participation, so getting beyond the administrative, the hospitals, the big health systems, and focusing more on getting providers engaged into those and empowering them, whether through risk or through potential monetary reward. Expanding beyond Medicare, Medicare Advantage becoming a very large part of our payment structure, but getting other commercial payers involved and perhaps managed Medicaid and Medicaid programs as well. And obviously that ongoing commitment to just shifting away from fee-for-service. We're seeing private sector focusing on consumerism. That's obviously been a big trend and it will continue. It's creating a lot of alignment across providers, pharmaceutical companies, technology companies, and payers. You're seeing a lot of payers actively owning pharmaceutical companies, payers purchasing providers, right? Payers getting into the game of managing risk by having a one-stop shop to kind of control the cost, control the flow of information. And really dictating a lot about where patients can and should go to receive healthcare. We feel that traditional providers are going to face a lot more competition from private equity-backed healthcare practices, more corporate looks on healthcare management, retail healthcare, and new individuals, new technologies, new products entering the market, focusing on consumerism, right? Shifting beyond the four walls of the traditional hospital, and focusing more on the consumer side. Where are people looking? You know, the rise in urgent cares and freestanding emergency rooms and retail clinics, but then telehealth, right? In the last 2 or 3 years has really become a big factor, a big component. And technology, the way that we can deliver care has rapidly changed as well. So we know we're going to see a lot more change for that. And for traditional healthcare organizations, we're really seeing that impact as a potential risk, but also opportunity. So where we stand today, organizations face a lot of hurdles to implementing value-based care. There are upfront technology investments, tracking patients longitudinally across the spectrum of care, making sure that medical record systems are set up right, having the right systems in place to track payments and outcomes and everything else under a value-based care model. The long-term administration and cost of these programs that last multiple years, having the right assets in place to manage them. They require a lot of data systems and software that may or may not speak well to one another. Workforce burnout and turnover obviously impacts organizations' ability to have continuity of care, but also to maintain a consistent focus on value-based care. Legacy processes, and I would argue training programs for healthcare professionals are designed and taught in a fee-for-service world. You know, a lot of physicians coming out of medical school are getting more and more training on the business side of healthcare and some on value. But the traditional model of medical school training is still very much focused on a volume-based world, because that is the reality of coming in, providing the best care you can to each patient you see. But physicians walk into the office in the morning and look at how many patients they have for the day. It's a very human thing to do, and that way the process, the mindset, the focus is still very much on volume, because that's what individuals are usually reimbursed on. And many payers offer a lot of value-based care programs. There are a lot of definitions of what value is. There's a lot of definitions of what success is. And there's a lot of reporting requirements and outcomes to manage. So any large health system, right, may be reporting outcomes, value, success for 2, 3, maybe up to 10, maybe up to 20 different programs, right? Different quality metrics. The definition of a readmission can change across these projects. What is required from a data aspect, what is required from a cost savings aspect, all those things come into play. And when you're managing that across 2, 5, or 10 programs, it becomes pretty burdensome. And so that's making organizations less likely to want to implement or be involved in more value-based care because of what it's taking, which is why CMS has stated that they want to kind of reduce that burden. So with all that, what can we do about it? And specifically, how can Stratizan and Syntellis help with that? So in order to position your organization for success, I like to tell our clients that there's 3 easy ways to start. One, you really need to understand your market. You need to know what are the high populations, what are the distinct populations, the high risk populations that you serve, and what are the high volume areas that matter to your organization. And that matters obviously from a bottom line, but it also means that you've got a lot of process in place, you've got a lot of volume to impact. And that also means there's probably a lot of variation or the opportunity for variation in cost. So if you treat 200 patients for the same thing, we all know no 200 of those patients will have the same experience, but that means more opportunity to maybe efficientize, make things more standardized. And that also means that payers are looking at those areas of importance as well. So payers are going to be willing to come to the table and talk specifically about ways that you could target some high volume areas. Take stock of the operational levers you can pull, assess outmigration, referral leakage, right? Where are patients going? Where are they leaking? How are our providers and patients aligned within our system? That's something that healthcare organizations are looking at, and more importantly, payers are looking at, right? How aligned can individuals be across a network where they know what the cost will be? Evaluate patient flow across care settings. You know, from a hospital standpoint, how many patients end up in the emergency room? How many are going to a skilled nursing facility versus home health? Those obviously all have very different costs, very different expectations, and patients typically not always aware of all those things. So healthcare organizations taking more ownership of care coordination and navigation and education for patients to understand what each of those aspects mean. Understanding your outcomes from a clinical and operational standpoint, understanding how your patients are performing and how your organization's doing by provider, by department, organization-wide. What are some of those areas that might be driving costs, that might be driving poor quality, poor patient experience? And all that kind of ties into understanding how are you tracking risk? What does risk mean to your organization? Is it purely based on finances? Is it based on quality, patient perception? The ability to understand that and then have a competency to manage it. So how are you tracking the potential financial loss, the potential impacts to patient experience, to patient loyalty, all play into the risk equation. And then the last piece, evaluate the reimbursement landscape. So understand how you perform against others in your market. Charles, you work quite a bit with our Medicare Reimbursement Analyzer tool, which takes a broad look at contracting rates across the market. Is there anything you can share on this last point on how we're seeing providers coming to us talking with questions about reimbursements?
Yeah, thanks again, Michael. The MRA, the Market Reimbursement Analyzer tool, is a visualization tool for reimbursement data. And you know, our North Star in building that tool was, historically we work with providers, was to give providers a leg up at the negotiation table, to provide insight into the reimbursement landscape for entire markets in a single place, a single tool. So we found that, you know, the MRA has been around for a couple of years now. We found that clients typically use that tool in a couple of ways. The first being pretty aligned with that sort of intended use, that North Star. You know, they use the tool for really an unbiased look at the market to see where they stand relative to a competitive fair market rate. And so there's several use cases that have evolved really since the tool's been on the market. But you know, I'll mention one as, you know, being sort of on topic with this shift that we're seeing. You know, if you are a lower cost care provider, like an urgent care versus an ER or ASC versus HOPD, what kind of rate increase might you be able to negotiate given your position against those higher cost providers, if you are able to see that landscape? So an example, and I won't use names, but we work with a regional urgent care provider that was able to go back to a payer and point out just how much less they were being reimbursed compared to a higher cost competitor, a higher cost provider in one of their markets. They were, you know, so they can point out if a patient comes to us, to our urgent care versus this high cost center, you know, it's there's room. Ultimately there's room for that urgent care to get a 3% rate increase, which translated into a 7-figure annual revenue bump, right? A 7-figure annual revenue bump. But for that payer, you know, it's still beneficial for them to go see this urgent care provider, even with the rate increase, right? Even with granting them that rate increase. So now their incentives are aligned, and they were able to see that using the tool, right? With that, those insights into the landscape there.
And Charles, is it fair to say too, as organizations like that regional provider you mentioned are looking at opportunities for rate increases, they're also potentially coming to the table with payers to negotiate an aspect of value or quality? Hey, we know there's opportunity for a rate increase. What if we take some risk in order to go up to our rate as well? Are you seeing any conversations like that, or could you see that being a part of what that tool is used for?
Sure, absolutely. I mean, you know, to the extent, and I think that example that I mentioned speaks to that a little bit, but you know, to the extent that, you know, most of these value conversations around value are really rooted in fee for service, right? Fee for service is really the foundation for these conversations around value. So if you can really get your arms around that fee for service landscape, which has, you know, historically been really blinded, you know, providers have been flying blind as far as that reimbursement landscape in particular. If you can really get your arms around that, and that all of a sudden becomes illuminated for you, you can go in and have a great foundation for those other conversations that are more nuanced, right? Where the market is shifting toward. I think absolutely it helps.
Perfect. Awesome. Well, let's jump into some data then. And I know we're going to talk a little bit more about that tool in a bit. So we're going to talk specifically about using data tools like ours to drive value-based care decision making. So we're going to kind of take a selected example, ABC Health System, not-for-profit health system located in Houston, Texas, covering kind of the greater Houston market. They have several hospitals, but the two we're going to focus on. Hospital A, their flagship facility, central downtown, provides the full suite of services, the highest acuity, and it really is the referral destination for their entire system, right? So in that traditional hub and spoke model, they are the hub. Hospital B is their newest facility. It is serving a rapidly growing suburb in Houston. It serves as an entry point into the system for a lot of new residents in the Houston market, but also for individuals out in that growing suburb. It's a younger suburb. They have a lot of obstetrics, a lot of babies. They have a lot of younger population, but also taking care of quite a few people from outlying areas that are then transferring into Hospital A. So going to look at that, use some of our data as an example of how this organization might be looking and evaluating what does value mean to their system. So just a quick overview of their market. Greater Houston covers 7.7 million people across their hospital footprint, and that number is projected to grow 5% in the next 5 years. So quite a bit of growth happening in that market population, already a large population they serve. You see the age breakdown there, about a quarter under the age of 18, about 13% over the age of 65. That 65 plus grouping is expected to grow quite a bit in the next 5 years. I believe the national average for growth in that cohort is about 16. So they are seeing more growth in the 65 plus population than the US average because they have a younger population. Also notable that the 18 to 44 group is growing as well. That's going to be, you're more likely to be commercial insured, a lot of younger individuals, younger families, and obviously the pediatric rate growing as well. So a lot of growth happening in the market, and even the 44 to 64 group declining a little bit, but not too much. The population insurance coverage, 55% commercial, 8.5% Medicare, and another couple percent Medicare Advantage. You see 12% Medicaid there, and then quite a few uninsured individuals. So as this organization's looking at what does value mean to them, how are they looking at cost, how are they looking at outcomes? Well, they've got a large uninsured population, which means they have most likely a high-risk population with a lot of social determinants of health. And so from a process standpoint, from an organization standpoint, really understanding the demographics of that cohort, really important for them to just understand value for the system at large. But when they think about the types of coverage their population has, who's going to be coming to the table? Who is representing the majority of the people in the market? Well, 55% commercial means that a lot of their focus in terms of value-based care might actually need to be with commercial payers, perhaps with Medicaid as the next largest payer. But if they really want to move the needle in terms of getting more people under value, having more of an understanding, it's going to be that commercial bucket, which tends to be a lower risk population from an outcomes perspective anyway. So definitely an opportunity there. And obviously in the Medicare front, certainly some populations they could dig into as well. So as they're looking at this market, they're going to start taking a look at where are patients across their system, what are their areas of high volume, high value. One of the things that organizations we're seeing take a look at is what is their value across the board? Where are volumes in a bucket? So this organization has strong cardiology presence and also a strong inpatient presence. So one of the things that our data allows you to do is look longitudinally across claims, across care settings. So for this organization, looking at inpatient volumes, where are those cardiology inpatient volumes going after discharge? We're able to see within 90 days from an inpatient stay, where by a care setting are those patients going? You see 0 to 30 days, 31 to 60 days, and 61 to 90 days. 22% within 30 days going to an inpatient setting, 6% to the ER. As you go towards 90 days, you're seeing less volume going towards the ER as a percentage and to the inpatient setting. So this suggests that maybe they're seeing a lot of readmissions. They're seeing patients presenting in the ER and back in the hospital inpatient setting within 30 days. So quite a few claims, the majority of claims, 40% or so happening within 30 days. This tells me for cardiology, if they're really thinking from a value perspective, that there's a lot of cost variation happening, that payers are going to be honing in on readmissions, on emergency use, and getting patients to lower cost care settings into areas that may be having better outcomes as well. They also could be at risk in that payers are looking at their readmission rates and considering whether or not they need to be in the network because the amount of costs that readmissions are going to be driving. So from a patient flow perspective, this organization might be looking at tackling readmissions for cardiology. Cardiology, obviously a very complicated field with a lot of touch points, but readmissions and emergency room use, certainly something that could be tackled with a partnership for home health, for primary care, getting primary care providers more engaged, or maybe a health at home program where you've got acute care in the home to take care of some of those higher acuity cardiology patients. So definitely opportunity to engage from a cardiology standpoint if this organization can make moves to reduce their spend, to reduce the variation, to reduce patients going into the inpatient setting. They're going to drive down quite a bit of cost. They're going to improve their quality, and that's going to be a win under value-based care programs. So looking a little bit more specifically at the ER side of this equation, what they might want to be looking at is, of those 6%, where are they going? Are they going within our network? Is that something that we can change? If they're all going to us, then we can engage our primary care providers in a meaningful way. Are they going somewhere else, right? Are these just really sick patients who are ending up somewhere else? So digging into the emergency room, I mentioned Hospital A, that's their flagship big system, and Hospital B, which is their more suburban location. Looking a similar look, patients discharged from Hospital A for an inpatient stay who came back to an emergency room. You see about 29–30% of them landed in their own ER, and then quite a few patients obviously going other places, different medical centers, different provider groups, a couple other areas where 2–3% of patients going quite a few other places. So patients leaving Hospital A probably quite a bit sicker, coming from a broader region. It's going to be harder to manage that network, to manage those patients' usage of emergency room, knowing they're coming from all over, compared to Hospital B, where they're seeing 41% coming back to their own ER. So you're seeing quite a bit more loyalty within the emergency room setting, that those patients out in their outer lying area may have more success engaging a ABC Health System provider for primary care, or a program used to divert patients from the emergency room. So again, using this data to understand, where do patients start, but more importantly, where are they going afterwards, right? And from here, you can really get a good sense of variations in cost, where the spend might be happening, where patients are going. You could even take it a step further to understand by physician, right? What is happening within these patients and these cohorts, to understand patient loyalty, and from a risk perspective, where are these areas of high risk? You know, if you know 2 or 3 of these emergency rooms are very expensive in the market, well, there's an opportunity to maybe move some of those patients elsewhere, to have better discharge planning, or better primary care engagement to help patients understand their option. Looking one more step further, if this hospital, this health system wanted to then say, now we know where our patients are going, well, what are we getting paid for these services? How are payers viewing us from a contracting percentage, right? Charles mentioned our Medicare Reimbursement Analyzer, our MRA tool, which allows you to see as a percent of Medicare, how are we being reimbursed for some of these services. So ABC Health System and their 2 competitors here, competitor 1, a for-profit system in the market, competitor 2 is an academic system in the market. Charles, would you mind kind of walking us through, what are we seeing here? What do these percentages mean, and how might you be looking at this from a tool perspective?
Yeah, you mentioned the percent of Medicare, so I'll unpack that a little bit. On the reimbursement side, we've received the entire 835 remit file from the clearinghouses. That includes the billed, paid, and allowed amounts. And that allowed amount is what implies a contracted rate between a provider and a payer. So we then crosswalk in the Medicare fee schedule, which is, universal benchmark in the contracting world. And that CMS fee schedule is rate adjusted by locality. So we get an apples to apples reimbursement across various markets.
Perfect. So when you look at this, right, you're looking at ABC Health System against their competitors for emergency room, cardiopulmonary services, for general medicine based on evaluation and management codes. A couple of findings stand out. ABC Health System, compared to their competitors, they're a high cost payer. So or high cost provider. So from a payer standpoint, they're looking at ABC Health System as an area that has really lucrative contracts for themselves, but also a place where the payers are having to pay out more dollars for similar services rendered. Competitor 1 may have incentive-based contracts in place for cardiopulmonary services, right? Compared to ABC Health System compared to what they're getting on the emergency room side, they're getting paid quite a bit less on a rate side for cardiopulmonary services. It may be a lower volume service for them, an area they don't put as much focus into for contracting. It could also mean that they have some risk in place, right, where they're getting paid less on the dollar for each volume seen, but maybe they have some quality incentives in place, some value linked into cardiopulmonary care. And really what this also tells us is that payers may be willing to go at risk with ABC Health Services, health system, to reduce emergency room care, cardiopulmonary spend. There is definitely opportunity here based on what we're seeing for this organization to come to the table with a payer, negotiate a lower rate, negotiate for more contract, more value-based contracts, to get more exposure, to get more comfort, and frankly, to demonstrate the ability to be successful in value, but also generate savings for themselves and their providers. So from a provider alignment perspective, from a patient engagement perspective, they really have an opportunity here to come to the table knowing that they are a high cost provider in the market. That means they probably have some decent outcomes to show that the payers are willing to pay this much. So they're probably in a good starting point. If they're evaluating whether or not to move into value-based care, this says there is going to be an appetite from payers, that they probably have decent outcomes, and from a cost perspective, they probably have some ability to negotiate to a value-based contract in a way that providers are not going to fight as hard as they would in another setting. So again, just another example of the ways that we look at our data, the ways that some of our clients are looking at our data to assess value and the opportunity therein.
Michael, one thing I'd add here,
yeah,
the rates that we're looking at, this is pretty rolled up, right? This is pretty aggregated. We're looking at an entire service line or care setting. What you would want to do, and so a great starting point for an analysis, but you would want to steadily march toward the code level reimbursement, right? Can we get down to a procedure code level reimbursement? And that's what our clients are able to do. That's kind of what you're steadily marching towards. In an analysis like this, also, can you look at individual payers, individual plan or coverage types? Are we looking at HMOs, PPOs, what have you? So that level of granularity is where an analysis, a starting point like this is where you would sort of steadily march towards.
Absolutely. Okay, so taking all that into consideration, just a couple quick hits in areas that we've seen value and driving value for value-based contracts. A couple key takeaways here. So one, value-based care is slowly evolving and growing in the reimbursement landscape. It's not going away. It's certainly not where we thought it would be, but it is a larger and larger part of the conversation. And what it means is actually changing. Like I mentioned, areas like health equity, areas downside risk are things that are a lot more important to payers in recent years. Providers are seeing impacts and challenges to implementing value-based care programs and probably will continue to do so. Our hope is that platforms like Stratizan and Centellus can help organizations understand the value, their opportunity for value-based care, and maybe track it and manage it effectively moving forward. As a starting point, organizations looking to have success in value should really focus again on understanding their market. What are the areas of risk? What are the high volume populations? What are the high volume areas in the organization where you're seeing high variance, whether that is within outcomes, whether that is within costs? Payers really like to hone in on areas where there are a lot of variance in healthcare spend, because it means there's opportunity to reduce the variance, to normalize, to efficientize, to make more process, to drive down cost and savings. Take stock of operational levers, understand the areas of high variance and cost for outcomes, establish competency for risk. And then last, evaluate the payer environment. How do you perform against others in the market as a starting point? What you are seeing is also what payers are looking at as well. And take stock of how payers view you in the market. Are you a high quality provider and a low cost, high quality, high cost? Where do you stand from a contracting standpoint? And how likely are they to do something innovative, different, value-based in your market? Really important for you to understand that lens, and then like we mentioned, our MRA tool can certainly help that. I should also mention that our newest tool coming live to the platform this month, Focused Pathway, is another tool that uses some of our claims data to really understand this at a deeper level. It allows organizations to look at claims volume across their market, look at out-migration, leakage, and referral volumes is a module we're building into it, where you can really track and understand which providers within the organization are moving the dial in terms of volume and out-migration, and really help organizations understand what are some of their high-risk, high performers, what are some of the high-risk providers, where are they really seeing alignment issues, and that data is being really powerful in driving conversations under risk-based arrangements as well. And so with that, Dave, I'm going to turn it back over to you, and we're going to field any questions that individuals on this webinar may have.
Awesome. Thanks, Michael and Charles. That was really good, really educational. We do have a couple questions. So first one is, have you had organizations use your tools for any specific types of value-based care?
Yeah, great question. So we have had multiple customers use our tool for value-based care. I think we've had payers come into the table within certain ACOs and value-based contracts, but we've also had organizations who are looking at certain demonstration projects like bundled payments. For instance, a hip and knee replacement. They're really trying to understand what are their volumes, what are their outcomes, what are some of the areas that they may target from a bundled payment perspective on the orthopedic realm. And so using our data to really understand what are the high volume areas, who are the high volume providers, and then what is happening to those patients after a hospital discharge. How many are going to home health versus skilled nursing versus rehab, really driving that to help them understand, are there areas where they can affect change and cost, and helping them make a go or no-go decision about whether or not to jump into some of those bundled payment decisions.
Great. All right, second question. Can you tell us how payers might be using this kind of data to plan for value-based care programs?
Sure. So I think Charles hit that pretty well. I think at a high level, payers are using our tool to understand, one, how do they compare against other payers in the market from a rate perspective, from a rate difference, but then also looking at some of these organizations to see what is their patient flow, what is happening, are there areas where these organizations could look to shore up, are there high risk areas within the organization where the payer may or may not want to go live with those organizations from a contracting standpoint. Charles, I know you work quite a bit with payers and individuals on MRA tools. Is there anything you would add on that side?
No, I think you said it well, and even back to the example of that regional urgent care that we work with. Our client was the urgent care, but on the payer side, they're able to identify low cost versus high cost providers in the market who they may want to align with. So I think that was another good example.
Great.
Great. All right, last question of the day. What are the biggest challenges for an organization switching over to a value-based model?
What I've seen is the biggest challenge is twofold. One, it is really understanding and tracking the right outcomes that are going to affect change. So you usually know the end goal. What is you have a certain goal for readmissions, or you have a certain outcomes goal, but actually tracking to understand progress, to understand what's happening live is really important, because a lot of these programs, you're getting data, you're getting performance data within the program, but it's dated. Just like HCAHPS and other survey data that we all see and use in healthcare, a lot of the data is dated. So organizations really trying to get a real-time understanding of how are they doing, and maybe even predictively, how might they be doing the next assessment date for value-based care. And then the second part I would say is provider alignment. So getting providers engaged and involved, helping them understand their referral patterns and referral flows. What are the things that they might be doing prescribing, what are the processes in place that might be actually driving cost or poor outcomes, and bringing them to the table and helping them collaboratively understand and tackle some of those problems together, ultimately driving savings for themselves and for the organization. So provider alignment and outcomes tracking, two of the biggest areas that we're seeing as challenges, but also things that organizations can take control of as well.
Great. All right, guys, thank you for your being our experts today. We really appreciate it. For our audience, two final things to wrap up. First, thank you very much for attending. We appreciate you taking the time to join us today. We hope you got something out of it, learned something about value-based care and the future of it. And second, just to let you know, if you have any additional questions for our speakers or would like to know how Syntellis or Stratizan can help your organization, please visit our websites. The URLs are on the screen now, and complete the contact us form, and we'll be in touch soon. But thanks again for attending, and have a great rest of your day.